Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, we talk about the treatment of COVID-19 in primary care. My guest is Dr. Peter Cohen, Associate Professor at Harvard Medical School and a primary care doctor at the Cambridge Health Alliance. Dr. Cohen has co-authored a widely used set of practice recommendations for doctors caring for COVID patients outside the hospital. Let's listen. Dr. Peter Cohen, thank you so much for joining me to talk about the primary care treatment of people with COVID. You're a primary care doctor?
I am, Josh. And when this whole pandemic, when the wave came to us in Boston, all our clinics shut down. And at that time, we opened up one clinic that was just for respiratory fevers and went to work there. And I've been working there ever since.
So just over the last couple of years, how many patients do you think with COVID or symptoms of COVID you've taken care of?
Oh, our team has taken care of thousands of patients with symptomatic COVID. These are patients usually who are not quite sick enough yet to require hospitalization or the emergency department. So they come and see us. But the majority of patients, of course, are cared for by our telephonic care. So a big system that's managing patients at home. So we see patients quite sick, but not sick enough to require hospitalization.
And what you've been able to offer has just changed dramatically. Take us back to those first days. I mean, what could you even do?
Well, yeah, it was, well, first of all, we didn't even know what we could do or if there was anything to do. So those first days, we were just honestly sitting with our patients, being with our patients. It was a scary time. Patients who are sick were often not able to be with their loved ones. And to have us to be able to sit in the room as long as they wanted to, comfortably with them, that really meant a lot to the patients at the time. And we were just doing the basics. We were keeping an eye on how they were breathing, how they felt when they walked around in the exam room. These very basic things, trying to figure out if they should go to the hospital, if not. And at the time, we had absolutely no medications that were useful. And really, a lot of it was trying to prevent them from taking or getting inappropriate medications like antibiotics or steroids.
Tell me more about what you mean that one of the challenges was keeping people from doing things that might be harmful.
Well, over that first year, when we didn't have any evidence that any medication or any treatment was effective, there was treatment after treatment that was being promoted, actually to the level that even the FDA gave its blessings to some. So we were dealing with a situation where patients would ask us about hydroxychloroquine, azithromycin, ivermectin. And the question was, in these days, in these scary days, when we didn't have anything that was effective, what to do about these sort of heavily promoted medications that sort of had a life of their own.
What did you do?
So we were constantly scanning the research for the latest to see if there was something that suggested that it was actually effective, that something would work. But we kept on coming up with our hands empty in that regard. We were never impressed. And we thought that the FDA's decision to give emergency use authorization to hydroxychloroquine, for example, was a big mistake, a disservice. And so we never prescribed those medications for our COVID patients, even when they were very sick. We wanted to make sure that we weren't causing more harm to these very ill patients at this time.
So eventually, some treatments for outpatients, for people who are not sick enough to go to the hospital, did become available. The evidence for them, became quite clear. Why don't you talk a little bit about those treatments and how you have integrated access into your practice?
So it was a really gradual process in terms of learning about the evidence of monoclonals. And often they were promoted even by the president before we had evidence of efficacy. That was a particularly trying time where we had the administration doing a hardcore press to promote monoclonals at a time that we weren't comfortable that we had solid evidence that they worked yet. Eventually, though, we did get that evidence. Of course, as now is obvious, many of those don't work with certain variants. So we've had to modify our plans, and we have to be very careful. But eventually we had access to monoclonals. And now the armamentarium is incredible. We have pills, monoclonals, and infusions of remdesivir, which all have proven efficacy in the outpatient setting.
So somebody shows up now, let's say I were to be exposed, get sick, show up in your clinic. Would I show up or would I do a teleconsultation first?
You would be speaking to someone on the phone first. You'd be speaking to a nurse or another provider. And then we would decide where the best place for you to get your care is.
I see.
The good news is that almost everyone who's fully vaccinated does extremely well and can remain at home with advice. But if you were sicker or unvaccinated, then you might come and see me in clinic.
Okay, so I come into clinic. I'm assuming, we're all wearing masks and there are all kinds of precautions being taken. Help me understand how you think through the different options for treatment at that point.
So there's a few key factors I'm taking into account. One of the very important ones is maybe the most important one, is your risk for developing severe disease. The benefits of the treatment is to prevent you from being hospitalized or dying. If your risk of hospitalization is so low to begin with, then there's going to be no benefit of exposing you to any medication, even one that's proven effective, because it won't further lower your risk if you're not going to die anyway. So first off is your baseline risk of severe complications. The next thing I'm thinking about is what stage of the illness you're in. This has a dramatic impact on how we treat patients with COVID-19 in the outpatient setting. And really, I like to think about it, have your symptoms started within the last 5 days, or has it been over 5 days from now? That's a very big difference. And given those, and then the third is how you're doing, your symptoms at the time I see you. So it's those three factors: your risk of severe disease, what stage of illness, or you stage the very early days of illness, and what are your current symptoms. We put those together and we treat you accordingly.
Got it. And so you mentioned a few different options. There's monoclonal antibodies. There are 2 medicines that have been authorized. And actually, you've got now the infusions of remdesivir. So a third. How do you decide between them? Are there advantages, disadvantages? I know you've got supply constraints. How does that all work out for what you offer patients?
Right. So, Josh, we actually have a new emerging one in addition to everything you mentioned, which is a form of monoclonal antibodies that are high titer. So these are monoclonal antibodies, those taken from patients who have recently recovered from COVID-19, and then measured to make sure they have a high level of antibodies. Those are also another treatment option for us today.
A plasma therapy.
Yeah, you got it. So here's how I stratify things, because like you're mentioning, we often don't have access to everything. And we also don't have access to delivering things. You might have the monoclonal, or you might have remdesivir in your community, but you might not have the staff to be able to infuse it. Remdesivir, for example, is a 3-day infusion. That's a heavy lift. The high titer convalescent plasma, that's an infusion, monoclonal infusion. But then we have 2 pills that you can go to the pharmacy and pick up if they're available. So how do I put this together? If we have access to everything, there is one of the pills that I'm most excited about because the evidence is strongest. And that's nirmatrelvir plus ritonavir, sold as Paxlovid. that has the best evidence and it's the easiest to deliver. So when that's available, I'd go to that first. If that weren't available, then I go, my second tier is the monoclonal antibody that works against Omicron, sotrovimab, or high titer convalescence plasma. Those would be on the same level, my second choice, if they're available. If that weren't available, if neither of those were available, I consider remdesivir if that could be delivered. Because it's a 3-day intravenous infusion, you're probably talking only in settings of institutional settings where you might be able to deliver that. And then my least favorite is the other pill we have, molnupiravir. The evidence is weakest. The safety of it is I'm most concerned about. So that's the one I'd go to only in a last resort. And I'd only treat older patients with that.
That's very helpful. Now, we've been reading that as with the vaccine, as with testing, there have been some major equity gaps when it comes to access to some of these treatments, that particularly communities of color have had less access, even as they've had more severe outcomes from COVID. What do you do in your practice to try to avoid that kind of outcome?
Well, in my practice, we serve almost entirely the underserved community. So that's basically our entire MO, which is making sure that our patients have access so that you don't have to be one of the top scientists in Boston to get immediate access to the latest pills. We're making sure that as soon as the research is available, as soon as it's available en masse, our patients are right up there in the top tier. Now, of course, that is complicated by logistics. Just because we're advocating for that, we have many patients due to language barriers, health literacy, that run into problems even when you have an entire COVID team making an effort to connect them with treatments. We unfortunately don't have these right in clinic with us. So everything's a complicated follow-up steps. And I way too many times see our own patients getting lost in the shuffle. And especially because you're dealing with a critical few days, you want to get these medications in as soon as possible, really soon. That lost time could be a big problem.
What's the system that should be built that would make it easier for practices like yours to get treatments quickly to people who need them the most?
I would want both the COVID vaccine as well as the ability to infuse monoclonals and have the pills that are most effective available right in clinic. So unlike the old days when we used to have the pharmaceutical closet, the pharmaceutical rep would come by and stack us with plenty of Viagra and everything else that was a big market, and we could take that and give it to our patients a little sample to get them started. I would love for Massachusetts to provide us with that, and if we needed a pharmacist on staff, that we probably would. These medications are complicated; they have a lot of drug-drug interactions. Let's get a pharmacist who's working with us right there. We're working in a clinic, outpatient clinic, right in the community that needs it the most.
Got it. Well, that's an agenda that I think is going to be important and perhaps would have implications for other diseases too.
I agree, Josh.
Last question. You started by saying at the beginning of the pandemic, you really were primary care doctors helping patients cope with the anxiety of COVID. How has that experience changed? Do you still see that as an important role of primary care? Are people still as anxious? Are you still sitting with them in that way? What has evolved?
It has changed. There's a lot more known about the illness, but the tough times remain. This week, last week, it's sitting with a patient who has COVID, who was just at their friend's funeral last week because they passed away from COVID. That's the sort of situations that are most challenging today. Everyone that we see pretty much has a family member, a loved one, a friend who, if they did not pass away from COVID, has been severely affected by it. So there's that. There's a sort of guilt of being a sense of guilt of being in our clinic and not as affected as some other friends and family. But these are the tough emotional aspects of it today.
Really dealing with the trauma and grief over the last 2 years, from the last 2 years, not just the actual illness itself. Well, it's obvious to me you're a tremendous primary care doctor, Dr. Cohen, and thanks so much for taking a little time from your work to join us on Public Health on Call.
Josh, it's my pleasure being here today.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McCusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.